Boa noite, como vai?
Hey, Marcelo. Buenas noches. How
How
are
are you? How things in Dallas? How's the weather?
you? Weather's okay. It's, I don't know, maybe 20, 22 degrees Celsius. A little.
Wow, that's wonderful. So that allow people to go outside and do some exercise?
Yeah, we had a good weather weekend. It was very, very nice. Up to the 30th.
Oh, really?
Sunny, very nice. Got some
Good,
rain the last 2 days. So,
good, good.
but it's
So,
not bad.
Carlos, thank you very much for joining us, for spending an hour with us. As I told you before, we have with us many doctors from Brazil and South America, and also we have many friends, many people from the normal population. Or they are not specialists, but it would be nice so people can understand our conversation. And I just introduce you for people here that you graduate in Colombia, then you made your residence program in Tennessee, and then you moved to the fellowship with the famous Frank Witt, and then you replaced one of the icons in vascular surgery, one of the greatest surgeons ever, the Dr. Patrick Clegg.
Yeah, that's
Am I right?
something I replaced him. He hired me, actually. He was the one that hired me. And
Yeah.
16
Was
years,
an honor being hired by Patrick Clegg.
correct. And I came to Dallas 16 years ago. He was here until 2011, and he retired in
He
20.
died, but he's still alive and do well.
He's still alive. He's doing well. He paints. He's a good. He does paintings. He says he's actually very good. I don't know if you knew, but he was a professional guitar. He likes the classic guitar. And
Oh, really?
yeah, every time you Google Pat Claggett, I mean, at least when he was still a surgeon, the first thing that came up in Google was his online lesson in classic guitar. He was a true artist.
That's amazing. That's
Yes,
amazing. My son, one of my son plays guitar also. So that'd be very interesting. One day we can talk to him about surgery. I would ask you to make that connection to us. What do you
sure.
think?
Yeah.
Good.
It's
Be very nice. So,
yeah,
Carlos,
surgeon.
just to start, it's a tradition here. We started asking people, we did with Stefan Halon, with Yoderich, with Nick from New York, Nicky Morrissey. How does COVID change your practice day by day in the last month?
Sure. First of all, I want to congratulate Marcelo. I saw, I think a little bit of Gustavo's interview. I saw a little bit of Stefan's interview. You're a true talk show host. The next hey, Fausto Silva.
Look at that. Look at that.
Yeah, you should just probably stop doing all these crazy branch evars and just start your own talk show in somewhere in TV. I'm sure all Global would love to have you.
So,
Well,
thank you. Tell us about COVID.
yeah. So, as you may know, Texas is a big state. And in fact, we say here in Texas that everything is big in Texas. And that's, I think, relevant because our state is so spread out that we don't have the crowding of the big cities. And even though, for instance, Houston, Dallas, and San Antonio, they are, big metropolitan areas. However, they're really spread out.
How many people live in Dallas?
So Dallas, the city of Dallas has about 1.8 million. However, the airport sits in the middle between two cities, which is Dallas and Fort Worth. So that's what we call the Dallas-Fort Worth metropolitan area. And that's 7 million people.
A lot of people.
Well, yeah, I think so.
But huge place.
Spread out. We don't
Spread out.
have, the crowding of New York. We don't have the crowding of European cities. I think that's been a huge factor in the fact that we did not have a lot of cases like New York had or some other areas in the state.
New York, California, Brazil,
Correct.
Rio, São Paulo.
We had cases, obviously. I think in the entire state of Texas, probably were around 6,000, 7,000, 8,000 cases. We're still under 1,000 deaths in the entire state. It's a state of 28 million people. So our number of cases is rather small. The university here in the University of Texas in Dallas, where I work, we have two main hospitals, general hospitals. One is Parkland, which is our county community hospital, and then we have the university hospital, more specialized. As an example, Parkland has daily more or less 70 patients with COVID, whereas the university only has...
In both hospitals, how many beds you have?
Oh, both hospital is more or less 1,800 beds.
1,800. It's a lot.
1,000. The other one has like 600, 700. And so, yeah, almost 1,800. The total number of patients with COVID in one single day in the two hospitals is 80. So it's very, very small.
Yeah. I can see that. So,
Dallas has a lot of hospitals. So,
how? Tell us the part of the job. Are you doing normal vascular surgery, only emergency cases, or the practice is not unchanged?
So, Marcelo, back in March, around the second week in March, the governor of Texas actually shut down all elective procedures, and most of our clinics were closed. Most of our elective procedures were actually canceled. That was a mandate from the state of Texas, from the governor. The issue is people were really scared that our healthcare systems were going to be overwhelmed, that we were not going to have enough supplies. And we knew how this was going to grow. We were seeing what was happening in New York. So we actually, for 4 weeks, we actually closed everything. We were only doing true emergencies.
So that was the beginning of March.
Yeah. So for the entire most of March and until maybe mid-April, first week in April, we were only doing emergencies.
So now we are in May.
Yeah.
How things?
So we actually switched to do clinics primarily through telehealth visits, which was interesting, because for a long time, we tried to do those, and although we had the technology, the main thing for us is we were never had approval for payments. So although we could do it, we would not get paid. Suddenly, within 2 or 3 days, everybody's paying for it because they realized that patients could not come. They actually were trying to push for patients not to come to hospitals or to clinics.
Of course, because for the insurance companies, if the patient goes to the hospital and gets sick, they're going to spend more money than pay you a consultation, a teleconsultation. It's
Correct.
money business.
So I think that's a good thing. We're able to start that and to implement days. It was actually within days that we were able to do that. And we were doing some new emergencies, but I have to say that in the middle of April, we started to open up. By then we realized that the number of cases in Texas was not going up. There was a flat curve. The cases were not growing. And so by a mandate of the governor in Texas, in the states, the governors have a lot to say on what happens in each state. So the governor in Texas decided that he was going to release or allow us to do some cases. And the initial day was that we had to reserve 25% of the hospitals for COVID patients. Same thing with our PPE, our protective equipment and all that.
So you restart doing elective cases.
2 weeks ago, 3 weeks ago.
Are the patients afraid when you call them, sir, come to get your aneurysm fixed? Are they concerned or they just go?
I have to tell you, in the beginning, back in March, patients started to call us to cancel the procedures. Even though, we had not called them to tell them that we were going to postpone, they were already canceling on their own. Once we restarted to do cases in early April, patients have not been afraid of coming to the hospital. They're willing to come, and we're seeing they're just coming freely. And actually, starting late last week, we started to do back to almost 100%. So this week and last week is being 100 normal caseload.
And Carlos, tell me one thing. We had an interview with Gustavo De Rich and also with Stefan Halon. And they both said for elective cases, when the patients arrive in the hospital, they get a CPR and a CT scan of the chest to see if they have COVID undetected. Do you have any protocol, or just if the patient is asymptomatic, just go to the surgery?
No. So that's interesting. We actually, at the university hospital, we required a COVID test, and it has to be the formal COVID test, not a rapid test. And so patients have to have a COVID test done 48 hours before an elective procedure. So they had
to includes your personnel, your radiologist technician, your nurses, your group fellows.
Just the patient, no us. It's just the patient that 40 hours before comes to the hospital, or we had drive-through areas where they come and they get tested, and so it needs to be within 72 hours of the operation. So do the test. If the test is reported as negative, then we can proceed. Now the rapid testing is not used because of the false, negatives, but we use the rapid testing. We don't use CAT scan here. We don't do anything else other than the mandatory COVID test for everybody that's going to have surgery.
Do the patients have to sign a paper saying that they know there is a pandemic of COVID? Because if they get, for some reason, they get a COVID after the procedure, they can sue the hospital and say, well, I got COVID in the hospital. Do they sign some special paper, or when no,
we don't make like that. We have areas for COVID, as you know, which are in certain areas of the hospital that isolated from the regular areas of the hospital. We don't do that. We don't ask them to do anything else. We just ask them to actually, just get a test.
And before we finish about the COVID, I know you have a family in Colombia. Do you have any news about Colombia? Because I haven't heard in the news here in Brazil how things are in Colombia from friends and colleagues.
I've been following the news there. I think there is actually similar to Texas. It's very well controlled. I think the total number of cases, I'm not sure. I think there are a lot of people from Colombia here. They can tell us exact number, but I think it's still under 10,000, I think.
But it's not like in New York, in like California, in Rio.
No, nothing like that. It's nothing like Sao Paulo, or actually the only country I know that has been affected other than Brazil really bad is Lima in Peru, and also Guayaquil in Ecuador. They were really affected early on, especially Guayaquil. Now we do have some people in the border that have crossed the border between Colombia and Ecuador. There has been issues with a lot of people from Venezuela trying to return to Venezuela because they don't have job.
We have Juan Varela in our. He told us that they have 1,200 cases. 12,000 cases. 12,000.
Okay. Past 10,000, I guess. I think okay, of deaths is really small. I think the government in Colombia early on, as you may know, you cannot fly to Colombia today. If I go there, I had to come private jet to go there because otherwise it's impossible to travel. They shut down the entire country.
Yeah, Carlos, like me, I enjoy and traveling around the world and get together with colleagues. And I know you also do a lot of cases as a proctor, and also you go to a lot of meetings in Europe, in Italy, in France. We have in October the meeting of Stefan Rolon. So how will you see things? Do you think that the world is going to change? You're going to not doing our proctoring, not meetings anymore? How you see things?
I think Marcelo, things are going to change a little bit, because I think there's one thing we learned about, virtual meetings and teleconferences and televisits, that they work. I think what we're doing now is awesome. Look at what you're doing. It's unbelievable. You put a lot of people together communicating. People, can discuss, have ideas, questions. I think it's going to continue to happen, and I encourage you to do it. I mean, I guess you got a new job now. But anyhow, I believe that we're going to continue to do this. We're going to continue to do a lot of the actual virtual meetings. I think meetings are going to be offered virtually too. I think it's going to be a push, however, for us to come back to the meeting.
Let me more specific. Do you think, what's your question? What's your answer? Huh?
Think
before. Do you think you're going to have a Frank Witt meeting in November in New York?
I hope so. I really hope so.
Hope so.
Yes.
I'll be there.
Because, we need to get back to conference.
I think.
And I think this is really important, because it puts everybody together. And that interaction, that personal interaction, the fact that we meet colleagues, but also industry, also, other side.
Very nice to hear that from you. And I know if Frank know about that, he would be very, delighted. So I hope one day we can get in touch with him and Jack, so I can interview him about New York, about the meetings.
Oh, he loved that.
I think he's gonna love to do that.
Yes.
Yes. And Dr. Alejandro from Colombia tell us more precisely that we have 12,272 cases in Colombia with 493 deaths. So it's not a lot, because in Brazil it's much harder, much harder. But although some states in Brazil, Brazil is as big as the U.S. If you take out Alaska, Brazil is bigger than the U.S. Sure. Only one state of Brazil, like Minas Gerais, where one of our friends, Ferber, is with us here now. This state is, you can put 16 times France inside, only in this state. So it's a huge quantity. And I've been in Goiânia yesterday. They have 8 cases. I've been in Cuiabá last week. They have 250. So Brazil have many realities. It's totally different. Like U.S. Mm-hmm. You don't have cases in Dallas and Houston, but you have a lot in California and a lot in New York, where you have more people together. I don't know about Boston. You have any news about Boston?
Oh, yeah, Boston has had a lot of cases. They were after, while the curve was late. It was probably 3 weeks behind New York, but yes, like Mass General, like Brigham and Women's, all these hospitals shut down. They were overwhelmed. Now the curve there is going down now, but they had a lot of cases.
Tell me your personal opinion now. I have mine. Mm-hmm. I have some countries like Sweden, Japan, Korea, Indonesia, that they did like a vertical, so people can go around, the business open. They just reinforce, use masks, keep distance, and they say with that they will avoid the second wave of the disease. And people stay at home. Maybe you get the second wave and hit you. So you like the quarantine totally, or you think that those countries are better? You have that idea? I know you are not an epidemiologist.
Well, like everything we do, right? I think extremes are bad. You know, my mother used to say that to me when I was growing up. Extremes are bad. You can just party because you had to go to school too, right? So I think that applies to everything. It's like endo and open, right? You have to balance what the patient needs, and I think this is the same here. I think lockdowns are terrible because they can actually screw our old economies. That's what we're seeing. We've seen a lot of issues with economy everywhere. Now, on the other hand, you cannot just go freely because you're going to have a lot of cases and a lot of deaths. I think the model is probably South Korea, where they were doing testing and tracing and tracking of cases early on, and they were very aggressive. Had the experience of the SARS from several years ago, and they
Yeah.
had the industry and ability to do it quick. We didn't do that. We do more testing now. We do more testing now than anybody, but it's testing that's been done 2 months later when we have 90,000 people already dead. So I think it's a mixed balance. I think we're right in opening and trying to get the lockdown. On the other hand, we need to do more testing. And I think if we do all those things at the same time, yes, we're going to have more deaths. Yes, we're going to have surges. But I think if we are serious about detecting cases and isolating the cases. I don't believe in self-quarantines. I don't believe in, all these things they're doing in Europe. Or need, actually. Marcelo, you come from California to Texas today, you had to self-quarantine for 14 days.
Oh, really?
Yeah, you come from Louisiana or New York to Texas. Texas makes you stay home for 14 days. It's crazy. And so
Great.
limit the ability to travel. And so look at what's happening today in Europe. So all the countries are reopening, but Spain tells everybody that you come to Spain, you have to self-quarantine for 14 days. Now, the UK and France, same thing. However, they make a deal between them that if you come from France to the UK, you come from the UK to France, you don't have to self-quarantine.
It is crazy.
That's crazy.
Well,
Difference between
Carlos,
coming from UK with Spain. You need to be able to detect the cases and isolate those people, not everybody.
yeah, you are totally right, and I agree with you. And I think the problem now is that the politicians, they want to make, like say, profit of the, they are not thinking about people asking if they can send questions in Portuguese. Podem mandar perguntas em português e em espanhol que a gente traduz para o Carlos, ok? Todos podem mandar perguntas. And Carlos, I think the politicians want to take advantage of the moment without thinking about people, like they always do. That's the truth. Okay, I have only a last question about COVID, then we'll talk about subjects that you are more, I know you study more and more famous. Luis Virgin, cardiólogo, somewhere in America.
Good friend.
Good friend. So he asked
Yes.
you only use PCR or EGG, EGM?
No. So for the testing we're doing for patients for procedures in the hospital is PCR. Now we are also doing, IgG, IgM, and IgA. Actually, we have IgG too, but those three testings are just for screening purposes or to make it up. Actually, I have my EGG, IgG, IgM, and IgA days ago, and it came back negative.
Okay, Carlos, you know what? Here, we take care of a hospital that they have many COVID patients, and we put a lot of catheters and we put a lot of filters. They have thrombosis of the arteries, of the veins. And then so, with that, I test my EGG and it was reagent, positive, without feeling nothing. So now I'm immune. And I also did my wife. So I think she never go out. So I think she got contact with my contact, and we are both now positive. So we are let's say, maybe immune to the disease. We have one question very interesting point that my friend from Minas Gerais, Leonardo Feber, is a very nice surgeon, nice person, and he does a lot of cases in aortic dissect type A, type B branches. And Feber make a very interesting question. We have already discussed it with Ulrich. What's your feeling about the U.S. hospitals? Revenue decrease. So health unemployment will become a strong problem. So you are doing less surgery. So the revenue of the hospital, like Mayo Clinic, like Cleveland, like maybe your hospital. So you think there will be some people going without job?
Oh yeah. That's been a big deal, especially for private practice. As you know, maybe 40% of the practices, healthcare practice in the US are private. So yes, the private practice had been really affected throughout the US because, you know, we had these mandates. In the beginning, people tried to keep doing cases, but when it became mandatory and it became from, you know, the governors, people had to stop because they were threatening you with jail or big fines or even taking your medical license. So people
really?
suffered a lot. Yes, we had that here because people were trying to still doing cases. And so the governor said, no, you're not going in. There's a mandate, and the Texas Medical Board, which is the agency that regulates our licenses, sends us some emails that were really tough, telling us you stop or we take your license away. Anyhow, people.
As you mentioned before in your talk, you said that the economic problem with lockdowns, etc., will be a strong issue in the next month.
Yes, and it's affecting obviously the healthcare sector. I think we're reopening. One of the issues is that obviously we are not. The problem is we have the patients with, you know, MIs, you know, strokes with symptomatic aneurysms because we're not willing to come to the hospital. So we're seeing more of those back. And they're also, you know, seeing more elective cases, patients that need to be done. Obviously, we're prioritizing who needs to go. I think that's reactivating the healthcare business. I think we did not suffer as much as other sectors of the economy. But yes, we got affected in the small hospitals, especially in rural areas, especially in Texas, in rural Texas. There was a lot of small hospitals that, you know, some people were not even opening again.
Does your hospital is a universal hospital? Do you receive patients only with insurance, or patients that does not have insurance?
So
they have only Medicare, or even they have nothing. They appear in the emergency room. They have the treatment.
So the university hospital is considered like a private hospital. You have insurance or some sort of insurance that we accept. But the Parkland Hospital is the county hospital that everybody gets. So we do both. But you know, as you know, anybody that comes be treated because that's the law. When it comes to one hospital or the other, we have to take care of the patients. But if patients come, you know, just for care, they go back on, you know, insurance happen. In the hospitals we take all, although I have what I told you, the university takes certain insurances, the other.
Like a patient come with a rupture aortic aneurysm, but when they arrive, they cannot inform you. They are like, you know, hypotension, and then you discover they have nothing, no insurance, no medical care. He's a poor man, but he has a rupture. So you go and treat him.
Sure. And in the US, you know, we treat all the emergencies. If patients show up in the emergency room, and there is
And who paid the university?
So there's an emergency coverage for those patients from the states and the federal government. If the patient doesn't have insurance, the federal government through Medicaid covers those emergency treatments.
So let's suppose the guy comes illegally from Mexico and arrive in Dallas with no insurance. He gets sick. rupture aneurysm, go to your university, he get treated.
He gets treated. He gets everything just the normal way anybody else. And that patient even is undocumented. That patient gets the treatment paid by Medicaid. The problem is they get into other troubles, but the emergency treatment of patients in the U.S. is covered of everybody. The problem is when you don't need emergency treatment, then nobody will see you. Unless you have insurance, unless you pay, nobody will see you. But if you have your emergency, you show up at the emergency, you have to treat that patient.
There is a question here. The user, what here is? IOM. Gauta asks you if you use the IOM for cardiac surgeries. If so, how useful do you feel it's relevant for cardiac surgeries? For that surgeries, would you prefer IOM? I did not get the question very well. If she could repeat, how you mean with IOM? So let's wait until she explains us. Tell me, I just come from doing 3 thoracoabdominals, and you know, I'm a branched guy. I think branches are easier. Branches, you can change the anatomy. You can change the side of the branch. You cannot do that with fenestrations. Yeah, so we had to go right. So talking about that, do you have any preference for branches or for fenestrations? I mean, let's say first for aneurysms and then for dissections. Let's divide chronic dissections and the thoracoabdominal aneurysms. Do you have preference, branches or fenestrations?
So I think that the fenestrations work very well for juxtarenal and suprarenal
Type 4.
Maybe type 4s, where you don't want to go too high, where you have relatively normal paravisceral aorta. I think the fenestrations work really well there. Now, you have 2 thoracoabdominals that are 1, 2, or 3, or 5. I think those are better treated with branch. You have more branches, you know, give you what you said, more flexibility, you are more secure. But I think I have to tell you, Marcelo, a lot of what I still treat is what we of type 4 thoracoabdominals. In those patients, you know, I try not to go that high if I can avoid it. And if I had a good, healthy aorta around iliac, I prefer to stay in that area. And to fix those aneurysms, I think the best option right now is fenestrated. We don't have a real good solution for that. As you know, the T branch means you got you modify it, but we're not allowed to modify T branches.
Well, you can modify devices, make fenestration.
Yeah, we devices, but you cannot modify the T branch because the T branch is not available commercially. It's only available to us through, you know, investigational.
Because when I treat a type 4, I can cut 1 or 2 stents. And more than that, we now create a kind of a window, posterior window in the T branch. So even a type 4, you open all the intercostals. We have made videos of that. It's very useful. You can use that. So even in an emergency situation, justifying, you cannot modify.
No. Well, we can modify other devices that are commercially available, but we cannot modify an investigational device. And T branch in the United States is not commercially available, so we cannot modify. Now, what I told you, if I have juxtarenal, suprarenal, have a good neck, have a relatively, you know, small aorta in that area, because I think you know, you don't have to go too high. As you may know, we love to do preloaded devices. It's relatively easy, very fast, and that worked very well for us. So it's a matter of preference, like everything. I don't think it's one or the other is better than the other.
Yeah.
What you have.
If talking about ischemic problems, let's medullary ischemic, spinal cord ischemia. Well, at the end, I know you prefer to stage the procedures I also stage how long. It's probably a general opinion to stage the procedures.
No, but Marcelo, but I have my own ideas about that. I don't believe the staging necessarily decreases the risk of spinal cord ischemia. I know that's what is being used for, and that's what we learned from the Cleveland Clinic experience, but I don't think that's true for most people. I think the reason to stage for me primarily is two things. First, I think that you decrease the amount of coverage, you decrease the amount of foreign material. So as you know, you have thrombocytopenia, you have systemic response, inflammatory response, all those things.
Sure.
When you less background or less foreign material, the reaction is less. It's better to do in two stages, using dividing the entire
shorter surgery, less contrast, less radiation.
But I had to be honest with you, Marcelo. You know what's the number one reason why I use it, which is the other reason why I use staging? Is cost.
Oh,
in
really?
the United States, we don't get paid by the number of stents we use. We get paid a sum of money for a particular disease. So I'm just going to give you an example. If you have a thoracoabdominal aneurysm, let's say a type 2, the amount of money you get in Texas, and it changes based on state, is more or less around $60,000 to $70,000. Now you can get up to $100,000, but, and I'm talking about the hospital, I'm not talking about the surgeon. The surgeon is paid separate. It's what you get, the hospital gets. Now, you do everything at once, and you get, let's say, $60,000 or $70,000, and you use 5-6 stents and all the branches. Well, you're gonna be broke. But you're spending more than $100,000. However, if you do the stage, then you get paid $60,000 once, and you get $60,000 or $70,000 twice, the second time. So now you have $120,000, $140,000. So that's the way you can actually compensate.
So after all, the hospital is paying to do the surgery.
Well, yes, but if you do two procedures, the hospital at least can get paid twice, because you're doing two different operations. You're meeting the patient twice, so the hospital can go to insurance or to Medicare and get paid twice. As opposed to getting just paid.
And I agree with you, and because I'm a strong believer that the most important is to do as fast as possible the surgery, less ischemic problems in the legs, let both hypogastric open. Usually we treat one side without touching the second femoral artery, leaving that open, perfusion all the time. So we do all the branches for one side, and then we close that side. So I think the ischemia is very important for the general reaction, the inflammatory response, and also for the ischemic of the spinal cord. Talking about spinal cord, how do you approach? How do you protect your patients if you drain? Yeah. Also, Gauta explained us the neuromonitoring role in ischemic protection.
Yeah. So this is the deal. As you know, Gustavo Aldrich has shown that spinal drains are not benign. And I have to tell you, a few years ago, I have run a patient clavics because they had coronary stents, and I had to fix their thoracoabdominal aneurysms. And I could not use the spinal drains because, nobody would place a spinal drain if you take clavics, at least not prophylactic. And I did like 5 or 6 cases in a row, and I didn't have any spinal cord ischemia in the patients. I then realized that nobody has shown that spinal drains really help for endovascular repair. So at that point, I decided to stop using prophylactic spinal drains. And I was first in the US consortium to do that. And everybody, even Gustavo and other guys like Chancer, they were like, what? And I did it because I realized that most paraplegias or most spinal cord ischemias, no, they don't happen during surgery unless you embolize. If you embolize, then the patient wake up paraplegic, and that is
nothing. If you embolize, nothing you protect.
Correct. Now, the paraplegias we see happen 2, 3, 4, 5 days later, or even weeks later. And it's usually because of hypotension. Patients get dehydrated,
Sure.
arrhythmias. And those patients don't benefit from the spinal drain before surgery. So we stopped using routine prophylactic spinal drains. We only use spinal drains when patients need it. Now, granted, we can do it because we have a good neurosurgery service. I call them, and within an hour or two, the spinal drain is seen. Not everybody can do that. We're fortunate that we can do it, so that's the way we do it. We stopped using prophylactic drains for everybody. Even extensive type 2 thoracoabdominals don't play. There is one exception, whatever, one exception. The only exception is patient that have, one hypoocclusive or both hypoocclusives, or patients that, we see a big adanquix, arterial adanquix, or patients that have one subclavian occlusive. Then there is a problem with collateral networks. Those patients we consider prophylactic spinal drain.
Now, also, Gauta asked you about the neuromonitoring.
Yeah.
Yeah, you do that. Gustavo did some, but he told me that he's stopping doing that.
So we had interest in doing that. We did neuromonitoring. We did somatosensory bulk potentials, SSEPs. We did motor bulk potentials. And I had to tell you, Marcelo, we don't, I don't know, over 200 of those. And what we've seen is that their utility is very limited. They only tell me that the leg is ischemic because I got a big sheet. So all I do is take it out. And if you do that routinely like you do now, and then, the benefit's very small. We started to use near infrared spectroscopy.
Yeah.
It's nice, it's cool, it's a number. I had to tell you, the only thing I like the NIRS is because it tells me, see, we had some issues pushing the blood pressure up. Because everybody tells you that, right? Just push the blood pressure up. Make sure the systolic is above 160 and the mean is above 90. Well, guess what? I had a couple of patients that actually stroke. I gave them intracranial bleed because we liberalized the blood pressure, that it went all the way to the 200s. And you have an 80-year-old patient or whatever, old patient, they don't tolerate that either. They bleed. So the NIRS helps me with that. As long as the NIRS is fine, it tells me that it's okay to have blood pressures of 120. It may be okay to have a mean of 80. And the NIRS is telling me that that's okay because I'm monitoring the, paraspinous, blood flow. So that's what I use NIRS for. But it's also what Gustavo says. It doesn't help you a lot.
Yeah.
I think
he told that.
Because of research issues, because we
Yeah.
want that.
Again,
it's limited.
We come back to the beginning. Do the surgery as fast as possible and put the hypogastric with blood as soon as possible. And that's the best for the patient spinal cord.
Yeah.
And we have a very interesting question. We have a very interesting question from Vadik Kuri, is a colleague, a surgeon, vascular surgeon here from here. He asked you a question. What's your opinion about doing a thorax endograft, an infrarenal endograft, and in the visceral, put a multi-layer to avoid visceral spinal cord ischemia? So he tried to play with 2 cover stents and in between put a multi-layer. What's your opinion about that?
Well, I think patients need an anatomic repair, and what that means is you need seal, and the multi-layer stents don't produce seal. The multi-layer only, allow flow through the scape. This concept of directional flow or right direction of the flow, it hasn't been proven. Quite the opposite. What happens is that some of the visceral branches can go down, and you have
I haven't seen those.
It has shown. I mean, there's several failures. I think that concept is not appropriate. I think multi-layer stents never made it to the U.S. Thank God. We never, not even.
God, it's not a good idea.
It's not a good idea. No, I think the perfect repair, the way you were saying, as fast as Marcelo can do it, restorative as much as fast as Marcelo can do it, but limit. Yeah, don't get hypotension, and be careful with how much the blood pressure too, because that can be what I told you, can be bad too.
We see a lot of changes among the guys that doing more and more thoracoabdominals. Gustavo, Rolon, you, Melisano, who will be our next guest Wednesday, and about the stents, the connection stent, the bridge stents. I just changed myself here for one Brazilian stent they call Solaris, which is very similar to fluids, but more flexible and go very easily without a sheath. So that helps a lot and make easier the procedure. So do you have for branches special, prefer balloon expandable, a self-expanding stent? What do you use for branches?
So Marcelo, unfortunately, in the US, we have limited options, and I have to tell you, the ones that we have are not great. We started using regular biopan or fluencies reinforced by self-expanding stent, just the way you did it, the way that there was doing it. It's cumbersome. They're not perfect. Sometimes they're too long, too short, and you don't have the support. So we moved from there to use in the balloon expandable body, or BX, became available. It's been okay. It's been better solution, but it's way far from.
We have a stopping in the connection. Could you repeat the name of the system? The Bentley?
No, the BVX, the balloon expand.
Yeah, but Gustavo showed some fractures of that stent, no?
I don't think fractures have been an issue. I think there's a couple of issues with the stem. First of all, not precise. You always thought that a balloon expandable stem can be really precise. The other thing is you can kink. Kinks is what's being reported, and you have to be careful, and sometimes you reinforce them. If you have an area of compression, it's better to reinforce it. So we use sometimes balloon expandable stents inside the PVX just to reinforce it to avoid it. It's not perfect, but I think it's better than what we had before.
As you said, we do not in general reach the point to say that is the stent for branches. We are still waiting, and while we're waiting, we have between 4 and 10% of renal occlusions. Let's say in general. So I spoke to Gustavo and Melisano. We are planning a study. I'm not sure if you saw the Voyager study for legs, comparing aspirin alone, and the other arm, aspirin plus rivaroxaban, Xarelto, 2.5 milligrams. And that was very interesting because they show a better patency, although they have more bleeding, but this bleeding was not significant. So so I spoke to Gustavo, why not do a study if we get a better patency for the renals, mixing low doses of Xarelto and aspirin versus another arm without Xarelto, with only aspirin. What do you think about that in general?
I think great study. I think we don't know how to deal with these things. For the most time we use aspirin and Plavix, but I don't necessarily believe that Plavix is optimal. I think depends on the vessels themselves, how big the vessels are, how much occlusivity you have. But obviously, we don't know what's the perfect regimen. I think that proves to be effective, and hopefully in a controlled trial, it'd be great. I think it'd be nice to take.
Yeah, that's interesting. I have another question about that. Is most of our patients, they are very sick, and some have the shaggy aortas.
Mm-hmm.
So Leonardo from Belo Horizonte just asked us, what do you think about shaggy aorta if it is a contraindication for doing an endovascular procedure, the risk of embolization?
Yeah, it's a difficult situation.
Yeah.
Said before, you know, strength or back 50-50. You had to obviously assess, you know, what are you using it for. In general, we tend to avoid them. But I had to tell you, one of the first few cases that where I tried fenestrated part 10 years ago was a patient with actually a bad blue toe syndrome. It was embolizing from a aorta that had several plaques behind iliac and SMA. This poor guy was on Coumadin and he kept embolizing. It was aspirin. He had to be placed on IV heparin and Lovenox, and still he was embolized. So he was desperate and having a lot of toe pain and all that, foot pain. And that was one of my first fevers. And actually, the way we did it is we minimized, obviously, the rotation, the movement. We clamped the aortas. We did one of those axe fem externals that Ivan Sef used to show. So we maintain that we did because we wanted to maintain perfusion. We didn't know how long it would take. And we clamped the femorals. We flush everything. And it went very well. And this patient is still alive after 10 years. We get to see him, and he reminds me that we can do it. But we also have other cases where, you know, we embolize everywhere. And we, you know, have seen that. I think shaggy aortas are not
You should not absolute contraindication, but you should study case by case, let's say.
And I think you should start the patients on statins.
We still have 5 minutes, and I want your answer for these two questions. One is for the petticoat technique, or whatever they call now, stabilize. Mm-hmm. And the second for the studies conducted by Belisano in Europe about the embolizing the intercostal arteries before the surgery in 2, 3, 4 procedures. So 2 questions. We have 5 minutes.
Sure. So stabilize, I think it's an idea. It's a nice concept. We try it, but I think, you know, we need for chronic dissection, especially. I don't think it works. It can be dangerous, especially, you know, in symptomatic patients. I had to tell you, I had some rupture from that, and I think it's straightforward. I do believe in the, you know, Knickerbocker concept that you know, Tila described. You can design a stent, like a custom-made device for that. That works well, but I don't believe in necessarily, you know, dilating every freaking, you know, strike through lumen, because maybe. Yeah. Now, as far as the what was the other question you asked? The petticoat and the
MISAS study. The study occluding all the intercostals before the surgery.
I think that's an also interesting concept, but I had to tell you, that's very difficult to do. Oh, that's a nice cat. It's beautiful.
It's a Bengal cat. Kiki.
Marcelo, the problem with that is very difficult to do, is not without risks. And it'd be hard to justify a paraplegia or an embolization in a patient that you're just doing embolization just for staging. And if we
and this risk, Carlos, will be multiplied because you have 3 or 4 procedures looking for those small arteries. We know it's hard, especially in aneurysms. So
yeah,
I don't risky.
Onset, I think it's hard to do too. Technically, it's very challenging, and you and I don't believe in staging. I mean, we do staging because of different reasons, not necessarily because, you know, necessarily we believe in it. But this concept really attracted to me at all. Maybe interesting to do it, and I support people that do it, but I don't believe that it will be practical.
Yeah, I totally agree with you. Totally agree. So we still have time, 3 minutes. So, Carlos, we have 3 minutes.
Mm-hmm.
First of all, I want to thank you for spending an hour with us. We know how busy you are, and has been a great pleasure. Hope we have time to do that again and talk about carotid disease. I know you studied that a lot. You'll be very nice for people. And thank you very much. It was a great pleasure to have you here. In my name, in the Cook Company, and the Tamussino Company, they all support us, adding with announcements, design. So it's very nice from them. And so,
Thanks, Marcelo. You might be wrong. Today's my clinic day. Today was a busy clinic because we're back to normal. I almost patients to see, so I had to do, but I'm glad I was able to do it. It's great. What you do is exactly what we need to do. Maintain the communication, maintain, we're rolling about what we're doing and learning from other people. It's
sure.
a perfect storm for us to realize that,
it is very nice to know in real time and ask people in an informal way what you use, why, and that's people love that. And also, I let you know that next week on Wednesday, we'll do that with Germano Melisano,
sure,
from Chiesa Service, and we'll do that 2 hours before at 4 p.m. Rio, 2 p.m. for you, because we have 5 hours difference time. So Melisano asked to do that at 4 p.m. Brazil. So if you'd like to, we can ask him live about the disaster study, about the stabilized technique. That would be very nice to put him in the corner.
Sure. I'm sure that, I mean, it's nice to learn, the concept behind all these things. I just, like you, we have our own biases. I think, those work for some people, but it's not practical to do for everybody. That's the main thing.
So, Carlos, great pleasure. Hope to see you in December in New York at Frankfurt meeting. And let you know that's this.
It'd be great, cut aorta meeting here.
All right, that'll be in June.
Yeah.
Next year. And this conversation will be recorded at this Instagram Tamussino for 1 day, and in 2 days goes to the YouTube channel of Tamussino.